Thank you, and good morning, everyone. And thanks to Jean and Alzheimer Europe and Charles from the Maltese Dementia Society for the invitation to speak and to be part of this exciting conference. I'm delighted to be able to share in this integrated care themed session here with you this morning. The centrality of this theme will come to the fore as I have the opportunity to tell you about some of the work that we in the Alzheimer Society of Ireland has embarked on in the Dementia Palliative Care space. In particular, I will talk about our feasibility study, where we began a process of looking at the feasibility of dementia palliative care by building a consensus around what it is, as well as signposting a future programme of work to integrate a palliative care approach within the existing landscape of services and supports. This morning, and as part of bringing you on some of the journey we have travelled, I will try to dispel some of the commonly held myths and ones that we ourselves had internalised around what we understood to be dementia palliative care. I will attempt to unpack its meaning both from a theoretical and practical application standpoint. The first myth I propose to dispel is that dementia palliative care is only about the very final dying phase of the lives of people with dementia. It's not. Palliative care for people with dementia is much more about living well with dementia from diagnosis right through to the end of life. Of course, it is about the final stages of life, but it encompasses much more, with key points in the journey representing times that palliative interventions are essential. The second myth that I will address is that palliative care for people with dementia is all about the specialists, and that this must be a specialised piece of work. It's not. It's about naming it and integrating it into everyday dementia care practice using an integrated life cycle approach. Of course, in a certain minority of cases, the specialists are needed and their expertise is required, but in the main, I will be arguing that dementia palliative care needs to become part and parcel and an added component of good dementia care. Which leads me nicely into the third and final interrelated myth I propose to dispel, which is that dementia palliative care will open the hospice floodgates, that people with dementia will take over all the hospices, and that we must begin to start to change the world of palliative care. It's not. Dementia palliative care is instead about bringing the two worlds of palliative and dementia care together, to create a safe space for the two voices to talk to each other, to learn from each other, build their respective capacities, so that in the main, dementia care practitioners can become their own agents of change and to know how and when to respond appropriately. But also that if and when it is needed, there is access to the expertise of the palliative specialists, organised in a systemic and integrated way. So no, dementia palliative care should not and will never open the hospice floodgates. 5 years ago, it was the Irish Hospice Foundation, the manifestation of the hospice movement in Ireland, who opened up the palliative care for all debate and the need to look at extending palliative care to non-malignant diseases. Over time, and as a result of the palliative care for all work, a number of dementia palliative care projects developed, one on advanced planning, one on interventions in the long stay setting, and finally a piece of small-scale research that we ourselves embarked on called Opening Conversations. Opening Conversations set out to look at how, as an organisation, the Alzheimer Society could develop a model of best practice palliative interventions for people with dementia and their families. We conducted a number of open conversations on palliative care and end of life with people with dementia and their families. What we found was that it was very difficult to talk about dementia and almost impossible to talk about palliative care and specifically end of life issues in an open and meaningful way. Lack of insight into the disease is common, as are low levels of awareness of the illness progression. In our research, people with dementia indicated their desire not to know what lies ahead and instead chose to live in the moment. So clearly we have a long road to travel before we get to the stage when a discussion on the future is a meaningful part of the journey of the person with dementia and their family. That research was published in December 2011, and it clearly indicated to us the need to push out this agenda way beyond ourselves. This ultimately led to a much wider piece of work to begin to put together the pieces of the jigsaw and to identify what is needed to bring dementia palliative care into policy and practice. And so the Dementia Palliative Care Feasibility Study was born, and a year later we produced our report. The feasibility project adopted a collaborative and consultative approach and included a series of consultation and dialogue pieces with almost 100 key healthcare professionals from across the dementia and palliative worlds, specialist doctors, nurses, allied health professionals, long-term care service providers and personnel from other support agencies. These dialogue sessions were further enhanced by intensive one-to-one engagements with palliative and dementia care specialists, clinicians, service providers and families. In this way, we started the process of beginning to identify pertinent issues for shaping the development of the concept, which was enhanced by the existing evidence base. The project also adopted an exploratory approach in order to signpost a specific work programme. From our engagement, it is clear that some dementia care practitioners are already doing dementia palliative care work on a daily basis, but the reality is that there's no systemic approach to this practice, and there is no sense of it being an integrated piece in everyday dementia care delivery. So in terms of our aim to start building a consensus around what dementia palliative care is and building a model, did we achieve this? Well, yes, we certainly began the process, but did we achieve a full consensus? Not at all. Different stakeholders have many differing views. Families and people with dementia have a very different view of the world, as do the variety of health and social care professionals and service providers, and even within these groupings, there are a wide variety of perspectives. I would suggest that there are still polarised views out there in terms of what dementia palliative care means, both conceptually as well as in practice terms. In a general sense, a consensus was reached that dementia palliative care reflects the qualities of person-focused dementia care and the holistic focus of palliative care. Both models share a person-focused philosophy and a set of underlying principles that emphasises quality of life, whole-person care, respect for autonomy, care of the person and the family. However, building a conceptual model of dementia palliative care is challenging, and today I will just name some of those challenges. Whether people die with dementia or from dementia is still a contested point. However, what is accepted is that dementia is a progressive, irreversible condition and the associated comorbidities are life-limiting. The very nature of dementia as a progressive organic brain disorder presents challenges in terms of the application of palliative care principles. The duration and unpredictable nature of the disease and the condition and its trajectory is also a very real issue. Communication, capacity, and the reduced ability of the person to have their voice heard at the more advanced stages is hugely difficult. Ethically driven decision-making poses many dilemmas for healthcare professionals in relation to timely and appropriate clinical interventions. This is especially true at the final stages that impact hugely on the lived experience for both the person and their family. In addition, the reality is that there is limited knowledge of what good dementia palliative care is in practice. The educational and training needs of a broad range of healthcare professionals are still unmet and skill sets underdeveloped. Dementia palliative care, and in particular the end-of-life issues that pertain, are generally speaking not part of the current models of care. The challenges to consensus building, if I am to be honest, threw up many more questions than answers. Those questions included, so where and when does dementia palliative care take place? And specifically, when does the dementia palliative care process start? And who should own this agenda? In general, the feasibility study advocates that dementia palliative care has to happen in the mainstream services and supports for people with dementia and be complemented by expert support from palliative care. So in essence, this work is owned by us in the dementia world, with shared and mutual learning and in some cases direct support from the palliative specialist. Furthermore, and almost unique to dementia, the best opportunity to start having the conversations and to plan for the future is as soon as possible, because too soon is never too soon. Families and people with dementia in our research acknowledge that these conversations must be part of a process and that timely information and professionally led prompts and supports are needed. From our work, we also learned that transitions or key events on the dementia journey are critical times for palliative care interventions. These include getting the diagnosis, transiting to community services, and admission to acute care, making the transition from home to long-term to residential care, and the onset of a comorbidity. But the reality is that very often these transitions are crisis-driven and not planned. In the absence of clear, integrated dementia care pathways and the crisis-driven nature of care, there is very little consistency in terms of the level and nature of care, and with very little opportunity for the healthcare professional to respond in a holistic, person-centred way. We are also continuing to struggle to find the appropriate language around this area that is commonly shared and meaningful. So, as you can see, we're not there yet. Further work, debate and discussion is needed in order to reach an agreement as to what dementia palliative care is and what language we need to use around it. But at least that debate has begun. The report we produced as part of the feasibility project also conducted an analysis to signpost a future programme of work. There are several recommendations in 4 domains: services, education and training, research, and policy and advocacy. I will just give you a sense of what is reflected in those 4 domains. In relation to the first area, services, there are a series of recommendations around developing evidence-based models and building capacity in the relevant sectors to become best practice learning sites. Other recommendations revolve around the development of a range of guidance and resources for healthcare professionals and service providers, as well as information resources for families and people with dementia. The Alzheimer Society is currently developing information products for people with dementia and families in relation to these areas. There are a series of recommendations in relation to education and training for the range of stakeholders. They primarily revolve around developing knowledge and the skill base at all the different levels of education and across the spectrum of health and social care professions. In particular, there's a need to strengthen the educational components for staff working directly in dementia care. The research domain recommends a call for formulation of a research agenda that spans the conceptualisation, policy, services and education areas. Finally, the policy and advocacy domain contains recommendations revolving around the need to have dementia palliative care recognition at a national policy level. Policymakers must recognise dementia as a life-limiting condition. Advocacy is needed to enable this to happen, and in order to highlight that this is an area that requires a level of expertise that currently doesn't exist, and the associated interventions have relevance right throughout the journey of dementia. Since we published our feasibility study at the end of last year, 2 highly relevant and noteworthy publications have emerged. Firstly, the publications emanating from the Impact FP7 study, in particular a paper by Dr. Steve Aliff and colleagues in August of this year entitled Modelling the Landscape of Palliative Care for People with Dementia, a European Mixed Method Study. Dr. Aliff and his co-authors in their paper argued that palliative care for people with dementia is often suboptimal, and this is due largely to the nature of dementia itself and the systemic failings that are particularly salient in primary and community care. It talks about the lack of wraparound or holistic approaches to supporting the person with dementia. The paper identified a number of high-level aspects of the landscape which have an effect on the quality of palliative care for people with dementia. These include the division of labour, coordination of responsibilities among practitioners of different disciplines, and the implications of this for learning, the structure and function of care planning, the management of risk and increasing complexity, boundaries between disease-modifying treatment and palliative care, and the process of bereavement. Secondly, the European Association of Palliative Care's White Paper on Palliative Care and Dementia sets out a series of recommendations that traverse a wide range of areas, including person-centred care, communication and shared decision-making, setting care goals and advanced planning, continuity of care, avoiding overly aggressive, burdensome or futile treatment, family care, and involvement and education of healthcare teams in their entirety. Both of these papers serve to provide very robust evidence to support our own small-scale piece of work and to reinforce our messages and recommendations. So what has happened since in Ireland? On the strength of this feasibility study and on the range of other palliative and dementia initiatives, this year there has been the development of a 3-year programme called Changing Minds. Led out by the Irish Hospice Foundation, the Alzheimer Society and other key stakeholders are partnering in the various work streams. Changing Minds will focus on developing dementia palliative care practice to include the development and adoption of practice tools and service models in the community, acute hospitals and residential care settings. It will also support people with dementia and their families to engage early in advanced planning. So, I hope I've managed to dispel the myths that I set out at the beginning using my best myth-busting techniques. If I haven't at least, then I hope I've challenged you a little bit by giving you some food for thought and a frame to think about palliative care for people with dementia. And finally, at this point in our journey, what have we learned? Really, that we are only at the beginning. We need to play the long game. We are slowly but surely finding the language and the ways and means to talk about it. And the research community, healthcare practitioners, Alzheimer organisations and people with dementia themselves have started to lead out this process of naming the challenges in the dementia discourse. I would suggest that Alzheimer organisations are particularly well poised to be part of the change that needs to happen, both in contributing to the concept and the practice. In particular, we can facilitate the voice of the person with dementia to be a central part of the discussions and to be one of the main agents of change in how best to deliver out dementia palliative care. We have also learned that clearly we need system changes and that we have to embed or integrate dementia palliative care practice in a systemic way. We need all those working at the interface of dementia care to understand, respond and act a little differently, to add in that extra ingredient and apply the palliative care lens. We need those working in the palliative care to be active partners to support those endeavours. We also need empowered people with dementia and families. We are still more than a few steps away from the reality of realising dementia palliative care. We need more work on the concept itself and significantly more work to make it a reality and to have it embedded in our everyday practice. In the end, it is about making the journey better for all, and this common denominator is what should motivate us to continue to pursue the agenda. But we also need a little courage and a lot of leadership, and let us be led by the inspired words of the wonderful Irish poet and Nobel laureate Seamus Heaney, who last month on his deathbed and within minutes of his dying sent a text message to his wife with the words in his beloved Latin, "Noli timere," do not be afraid. Thank you.